welcome back to the Advancing Healthcare Innovation Show. I'm your host, Michael Stamatinos. And if you're new to us, super excited to have you here because we're bringing some really encouraging and exciting conversations with leaders that are painstakingly changing the future of healthcare. And we're very, very passionate around access to care, healthcare innovation, adoption, and leadership. And if it's your first time tuning in, let me just take a step back and tell you what we're trying to do here. So we're focused on bringing stories of innovation to life, not just theories of innovation, rather digging into the trenches with real people that are really innovating within our space and giving them the platform to be able to share their stories, not only just with our community and also with the world. And if you haven't checked out any historical interviews, make sure you hit the subscribe button now so that you get any new ones that come right to your inbox. And our field is fast evolving. And it's crucial to have leaders that can really envision the future and eagerly embrace innovation to address many of these pressing challenges that we face today. And our guest on the show today is one of those leaders. I'm incredibly fortunate to know this innovator, Dr. Gerry Petratos. He is the co-founder and CEO of HITEKS Solutions. Dr. Petratos' journey is actually truly inspiring, blending his expertise in medicine, research, and tech to really lead the charge in transforming healthcare through innovation. He found his true calling, not just in being a physician, but really he's on a mission to use medical informatics to change how healthcare professionals get vital information when they need it the most. And his current work with HITEKS is focusing on enhancing decision support, improving clinical documentation, fueling clinical research, and streamlining reimbursement processes. And before his time at HITEKS, Dr. Petratos honed in his expertise as the director of clinical decision support as the global head of healthcare data and analytics at Roche. And with his leadership and vision, it's been crucial in developing innovative solutions that integrate seamlessly into physician workflows, allowing for more efficient patient care and helping hospitals improve their coding practices to capture necessary revenue. So Dr. Petratos, it's great to have you on the show. Good to see you. How are you?
Thanks for having me, Michael, and please call me Gerry.
All right, Gerry, we get to do that. So let's dig in. So we've kind of went into a little bit of your background, but tell us in a little bit more detail to the degree that you're able to, tell us a little bit of your story and how you've kind of come into HITEKS and what you all are focused on now.
Sure. Well, and I'm honored that you call me a leader. I'm actually a leader only because people that I work with, will refer to me that way at times, and then other times, people that I'm supposedly leading are telling me what to do, and I'm okay with that too. So, but it's an honor to be designated in that capacity in the healthcare industry, and I've entered the business world in pharmaceuticals, as you mentioned, after my fellowship in medical informatics when I was at the University of Utah and Intermountain Healthcare. And from that time, we were really focused on the science of informatics and trying to provide analysis of what can be improved in healthcare to make it more efficient. Mm-hmm. And since then, I've gone on a journey where I've been able to identify the really high value areas with respect to return on investment, because it's important that, most of our clients, they have committees that, review the return on investment for the software or technology that they're onboarding. So we've had to do a lot of work to show that the revenue or the associated value increases proportionally, upwards of 10 times the amount of money that they're providing us for software and services. Sometimes it can be even greater, but that's been a continuing activity on my end and my team, where not only do we develop the software, but when we market it, we have to show the example of that value.
That's right. So early on, I remember we had kind of talked prior, you had done project with a wide range of of EMRs, and early on you had taken a bet to say, hey, we're going to focus just on Epic. Can you talk through that decision making? Because that was a number of years ago, and obviously Epic has continued to kind of capture more and more market share. Talk through the reasoning behind that, and then I also want to kind of dig into sort of the difference between being integrated versus embedded within the Epic environment.
Yeah, thanks for mentioning that. Our perspective has been, first of all, we got involved with Epic clients early on, so it wasn't something that we necessarily sought out, to work with one EMR. But what happened was we realized that each EMR is so different with respect to the interfaces, the workflows, and standards. And because of that, along with the background that I had in medical informatics, where there was a lot of controversy at the time, which is 20 years ago, when I was in the program, around interfacing systems together for best of breed versus having one system which more efficiently was able to communicate and support workflows rather than having interface systems present. So the in the early days, interface systems were the goal, and that's why you had a lot of hospitals, purchasing one EMR for their clinical workflows, another EMR for their revenue cycle, another one for their scheduling, another one for their lab system, and there are probably a few of these legacy organizations still, in the U.S. Or internationally, but for the most part now, people have consolidated onto one system for all of their, I'll call it their interfaced needs, workflow needs. So, and also the fact that there's a single database with both Epic and with Oracle Cerner, along with Meditech and the other big ones. The fact that there's a single database, a single set of workflows, a single set of requirements and standards for their interfaces makes it much simpler, and I'll say safer to work with and focus on one EMR. And so we continued that, that decision making. And even though we did work with some other EMRs like Meditech and Cerner and Athena and some others, we ended up deciding that our product can be the best it can be only if we focus on one EMR. And that's pretty much a differentiator for us with other vendors, because other vendors, they don't want to give up market share with the other EMRs, and sometimes they cannot provide a single product. They need to support the entire market because they're big enough and they're important enough. With us, we decided on Epic, and Epic also took some faith in us, bringing us in early on with some of the documentation workflows and helping to automate them because of their importance and because it was an area of engineering that they were not supporting at the time themselves, which was natural language processing. So, fast forward, that was back in between 2013 and 2017. So fast forward 6 years from 2017, and now they're starting to adopt new technologies like large language models and other technologies that facilitate some of the things that we do. But for the most part, because we created a built for purpose documentation improvement or integrity solution that's focused on both quality and revenue, we're continuing to optimize that, and it would take many years for some of these other technologies to catch up.
So we hear a lot within the marketplace talking about, integrated with Epic and this and that and the other thing. What you and your team have focused around sort of embedding. Talk about What's the difference? What does that mean? And
Yeah. So
how does that operate?
embedding basically means that the EMR system has created a framework for supporting certain workflows, and that framework is it has a user interface aspect to it. It has a database aspect to it where you record information, and it also has bells and I'll call them bells and whistles, where you want to be able to facilitate alerting providers or administrators of certain pieces of information. And so that framework that the EMR vendor provides becomes powered by us as a third party. And that's my definition of embeddedness.
Mm,
So, and the difference is that when the user is performing certain functions in the EMR, they don't know that they're actually receiving intelligence or advice from HITEKS. They're just in the EMR and they're receiving that information as though it were natively being supplied either by the EMR vendor or by themselves, or maybe by a human in the
mm,
background. So they don't know where the advice is coming from. They know that the advice is related to something that they put into their notes because that's what we're powering. We're powering the ability to highlight and identify relevant evidence in the documentation that um, can be improved in some capacity. And it also means that they don't need to leave that screen in order to answer the advice. A lot of other systems who are interfaced with EMR, they might have a tab in the EMR, but ultimately it's distinct from the normal, I'll call it the normal workflow. And so if you want to get information from that tab into the notes or into another place in the chart, like the flow sheets or some other area, you have to copy and paste, and you have to leave what you're doing in order to enter a different workflow. And so by definition, that's not embedded.
mm. Are there any, we're seeing a lot of, I'll just say, I'm seeing a lot of headlines just around security, cybersecurity, and things of that nature. Is one more secure than the other, being natively embedded versus integrated?
From a security standpoint, most of the new solutions are cloud-based, and being cloud-based uh, is no more or less secure than it is if it's an on-premise installation.
Mm,
Uh, the only difference is that the people doing the management of that cloud environment are different than typically they're different than those that are doing it for the main EMR installation. And so there's a number of reasons why cloud-based systems are the prevailing type of system out there.
mhm.
And it's important to understand that security can be just at the same high level that it's required um, for on-premise installations.
Mm. I want to switch gears just for a second because we've had conversations around this and the thinking around, building tools that are there to amplify physician, you being sort of a physician, kind of place yourselves in the shoes of a physician. Whereas maybe other solutions take the premise of, hey, we're gonna focus more, on the patient. Talk through the thinking through that on how you are creating useful tools, for physicians. Just talk us through that because I think that's really important for some of the audience to know about that.
Yeah, our approach has always been to focus on provider information because they're the ones that are responsible for consolidating all the information that they get in order to make an interpretation of a patient's uh, condition, how to best evaluate it, um, diagnose it, manage it, treat it. And so because of the fact that information exists in still in many silos, even if it's in the same EMR, it's still part of a silo. And a lot of times you need to access information from outside the medical record of that institution, and you need to grab information that is out there for a particular patient, or maybe even to reference, find reference material that is applicable to that patient. The provider's job has been traditionally arduous and uh, repetitive and inefficient. And that's not just true because of digital systems. That was true even when we had paper records. The only difference with paper records is you would follow a regimented process of getting a chart that you didn't have access to immediately faxed to you, and then you could view it that way. And then if the patient was an inpatient in the hospital, then you knew that that chart was at a particular part, placement in the shelf. And so
Hmm.
you can grab it and, and you can look up, the relevant facts from there. So the, the part that we've identified as the biggest challenge in provider systems is information synthesis and access. And so that's what we've helped to streamline over the years. So our system will essentially read through all the documentation, access relevant observational data, which is in the form of vital signs, medications, laboratory test results, flow sheet records, and synthesize that for the provider. And we provide suggestions of what they should consider in their documentation so that it becomes more complete.
Hmm. When they weren't, when they don't have access to HITEKS, even though it's natively embedded inside of Epic, how do they go through that process? Is it very cumbersome, more arduous? Like, how are they doing it out, in existing state outside of what HITEKS is doing?
Yeah, so we provide a an automation solution, but you can certainly do providers can certainly do their job and satisfy the administrative requirements without us. The difference is that the traditional process of having nurses and physician assistants and physician advisors and other providers who do the chart reviews, combing for opportunities to improve the integrity of the record. They do it manually through the arduous process of constantly reading through those charts and sending essentially emails or in basket queries to the provider, which get answered after the fact. So that is the standard process that's been in place for many years, and you can still do your work as a physician. The difference is that it can take upwards of 10 minutes to answer each question in the traditional way, whereas in our way it takes 20 seconds. So that's really the time savings. And then the other advantage is that they can do it before they save or sign their notes, and therefore no one's going to question them why they went back in to make an update to their note, which is called an addendum. And addendums are now flagged for compliance purposes, and payers, insurance companies, as well as governmental payers, they look at that in a negative way. So if you change your documentation, they want to know why. Did someone
Hmm.
coerce you to do it? Did someone lead you to do it? Or did you go in naturally? And typically the answer is somebody flagged the chart and suggested that change something. And then that opens up a whole can of worms that can best be avoided by using this automation.
So you mentioned a few different things, and then you had a previous comment that you mentioned the word legacy, and I started smiling because I had gone through one of your posts and I flagged it. So in this segment, I want to read something that you've posted. I want you to kind of get a little bit more color around it and get your reaction to it. This is great. We didn't plan this beforehand, audience. We did not. We didn't have questions were not sent in advance, but this is really fun. This is the quote. As I sat on the tarmac for a couple of hours yesterday, and again tonight waiting for resolution, yesterday's legacy transportation systems failure reminded me that we are in a store for a familiar one in healthcare. Legacy clinical documentation improvement systems are leading the inefficiency amongst revenue cycle in healthcare and need to be immediately replaced with modern and responsive point of care systems for doctors rather than HIM systems for coders, which are trying to appease doctors. Preventable delays and failures in hospital getting paid from insurance need to stop. I'll pause there and get your reaction to that. And that was from an article that was listed in the Wall Street Journal about FAA pilot alert system breakdown followed by years of warnings.
Yeah, thanks for reminding me of that post. I remember that I was caught up in the delays when I was on some flights that week. And then I read the journal article and I said, wow, that was exactly what I experienced, which is basically all of, the entire tarmac of full of planes that were not able to take off because of these legacy communication systems that they have in place. And so it came to the forefront for me that healthcare is really no different. We're still using these legacy systems, and people have wanted to create efficiencies around administrative processes, which is why they've implemented computer assisted coding and other downstream kinds of automation and efficiencies, but they've really delayed bringing similar technologies like ours for providers, which is essentially the group that has the biggest stake in healthcare that needs to become the most efficient for, if you will, they're the rate limiting step to having everything else be more efficient. Because if you can get the provider to acknowledge a diagnosis or a treatment and move it along through the process, that essentially frees up everything downstream that is relying on that one diagnosis event to be finalized.
Is it you being an innovator and being able to see farther ahead? How frustrating is it knowing that you see this bottleneck so clearly, and yet you're starting to see it nudging along? How do you continue to keep level-headed and your team level-headed that, hey, things are starting to change? How do you continue to sort of deal with the fact that there are folks that are okay with the status quo and that that it can be immeasurably better? And it's not something that's just so drastic that you have to completely re-engineer the way they're doing things. It's like a 2 millimeter shift. How do you and your team sort of continue to keep balance throughout that?
Well, I think our approach has been to, and I picked this up when I was in pharmaceuticals. Our approach has been to fail fast. So essentially, we want to be presented with a problem. Oh, there's a big bee here near me. That's the risk of being outside. There's the concept of failing fast is one that takes an approach where you're not willing to give up on something until you see that it really requires a different type of solution. So I'll give you an example of that. When we're presented with challenges of identifying surgical patients before they go to surgery,
Mhm.
and the reason why we need to do that is because we need to design specific logic and advice for the intake nurses, anesthesiologists, and the surgeon before they even take that patient into the operating room, so that we can obtain as many relevant comorbidities and also clarify what the final diagnoses are for the reason for surgery. and also make sure that we capture the complete surgical procedure with the highest specificity. So, and then after the surgery, there's other types of queries that we want to, other advice around excluding patient safety indicators. So, but the challenge is that we've been presented with: how do you identify a surgical patient before they go to surgery? It's really easy to do it after they have the surgery,
Yeah.
because everywhere in the chart it says that this is a surgical patient that just went through surgery. Before, you have to kind of be creative and look to either a scheduling system to see if they've been placed onto uh, a a calendar where they will have a surgery. It could be an hour, or it could be in 5 days. Um, or you could start monitoring for the type of visits that they're going for, going into for the pre-operative assessment. And and then there's other methods as well. So we were really stumbling on the fact that not all surgical patients are available in the scheduling system. They're, a lot of
Right.
times, if it's an emergent surgery, for example, or a lot of times the patient won't confirm that they're actually going to go to that surgery, and so they're not available in that system. Another place in the chart was the admission, discharge, transfer, patient registration system. So that allowed us to potentially get access to the patients a few hours before surgery, but then
Right.
that wasn't early enough. So we had to devise additional mechanisms to identify those patients, which ended up including a combination of these factors, including whether there was an order for, there's usually an order set that's ordered by either the surgeon or the referring physician, and that's placed into the EMR systems
Mm.
order entry. And so that ends up being another source. And so we had to compile all of these and then use essentially pieces of all of them in order to get enough insight of which patients to target with our advice, and uh, and also by extension which providers would receive our advice as a result of them preparing for this surgical patient. So reason I mentioned that is that without, in the beginning, we were failing because each one of these steps took multiple weeks to
Mm.
out. But we wanted to see if in fact we could support this requirement of providing the advice for surgical patients. And so we approached it as if we were going to fail. But if we were going to fail, we wanted to do it as soon as possible so that we could move on to provide value somewhere else. Because all these technologies are run by teams that have limited bandwidth, and you need to prioritize and focus our time in each of
Yeah.
these opportunities. So if we were going to fail, we wanted to do it as fast as we could, and we have done. We have failed in other areas. We tried launching an outpatient solution a couple years ago with respect to just improving what the EMR was doing in identifying HCC related diagnoses, and we realized that we really couldn't move the needle on that particular metric very much, and so we decided that we weren't going to pursue that anymore. So we realized that our value was in areas that were still open to providing innovative solutions, and so perioperative became one of them, and then emergency medicine is another one that we're actively pursuing in order to provide value. And then the third one is our continuing to expand the quality areas on the inpatient side.
Awesome. So I know we're kind of coming close to the end of our time, but you have always been someone that has continuously reinvested back into the R&D, and that's sort of the ethos of the company. Just sort of share with the audience a little bit more about how people can continue to follow you, your work, and the work that HITEKS is doing.
Well, we've launched a newsletter through LinkedIn, which now has a pretty good readership, and that's really helped us uh, provide regular communications. We in parallel have a blog that you know that we have multiple different authors. It's not just me expressing myself, but we have different viewpoints that we want to share, and also some of the uh, our successes and failures are communicated that way. And so our hope is to be transparent with what we do to try and make our systems as efficient and effective as possible for providers. And the the other area is we do participate in industry conferences and webinars on a regular basis. So, in fact, I think one of them that I uh, I presented at, which was the Indiana Health Information Management Association conference, which was in April. We're now just releasing kind of blogs and the video and associated material that was associated with that webinar. So yeah, we're kind of keeping active with that on social media. We also have recently opened up a YouTube channel where we're providing more and more insight into the workflows themselves, so that they're not cryptic and it's not arduous to learn about what we're doing. And finally, we have regular communications with Epic, since we collaborate with them as our sole EHR uh, vendor that we support, and so Epic has been really great at keeping us informed on the latest developments on their side, how they're also evolving their system for their customers. And this summer there's the user group meeting that Epic provides, and then we're also organizing a user group meeting on our side so that we can more regularly get structured feedback at predetermined times from our users.
That's amazing. Gerry, it's been just a pleasure to have you on. Thank you for just all the things that you're doing, just being very forthright. And for those that have tuned in, if you found this conversation meaningful, what would be great is if you wouldn't mind sharing it on social media or commenting on it, liking it. What were some of the things that stood out for you? Gerry, I'm looking forward to future conversations, and obviously you're always welcome to come back.
I appreciate that, Michael. It's been an honor to be part of your show.
Awesome.